Okay. Greetings and warm welcome to everyone. I am Rimpa, your moderator from Clarnet, and it is my absolute pleasure to extend a heartfelt welcome to all the delegates joining us from across the country today. We are privileged to have the invaluable support of our esteemed doctor, and I want to thank each and one of you for taking the time to be here with us. Your presence truly enriches this gathering. So before we proceed, allow me to introduce Clearnet as one of the India's largest live digital continuing medical education platform. ClearNet serves as a dynamic space where doctors can create, share, and engage with innovative medical content, fostering learning and collaboration in the medical community. Now, it is my privilege to extend a special welcome to our keynote speaker for today, Dr. Amitar Bhattacharya Banerjee. Dr. Amitav Banerjee, an esteemed epidemiologist and professor emeritus from Department of Community Medicine at Dr. D.Y. Patil Medical College, Pune, with distinguished career dedicated to public health, research, and medical education. Dr. Banerjee has made significant contribution to the field of epidemiology, shaping policies and training future healthcare professionals. Thus, we are honored to have such a renowned expert with us today, share his insight on the topic, the relationship between dengue fever and antibody dependent enhancement. So, before delving further into our topic, here is a brief description of the topic. Dengue fever caused by the dengue virus is a significant global health concern, particularly in a tropical region. Antibody dependent enhancement is a phenomenon where pre existing antibodies from a prior dengue infection or vaccination can paradoxically enhance the entry of the virus into the host cell during a subsequent infection with a different serotype. This occurs when antibodies from a previous infection bind to the virus but fail to neutralize it, instead facilitating viral entry through Fc receptor on immune cells. ADE can lead to more severe form of the disease, such as dengue, hemorrhagic fever, or dengue shock syndrome. Increasing the risk of complications, understanding ADE is crucial for vaccine development and improving strategies for managing dengue infection, as it helps minimizes the risk associated with subsequent infections. So now, without much delay, I would like to hand over the session to you, sir. Please proceed with your talk.
Thank you, Rimpa, and I am happy to come on ClearNet platform to share my views on the topic, which is dengue and antibody-dependent enhancement. And Rimpa has given an overview. This has implications for, it has clinical management, implications for clinical management, implications for public health, and as she said, implication for development of vaccines. So I will be sharing a brief presentation. I'll just try to share the screen. I think I'm sharing the screen. So this is the topic today, relationship between dengue fever and antibiotic dependent enhancement. So these would be the talking points. Overview of the epidemiology of dengue, you are well aware of it. Dengue virus serotypes and antibody-dependent enhancement, what it is, and clinical public health challenges due to antibody-dependent enhancement, and implications of ADE for vaccine development and prevention strategies. So, as you know, most parts of the tropical and subtropical worlds are endemic for dengue fever. Almost half of the world are at risk. And dengue is a viral infection transmitted by the Aedes mosquito, which breeds domestically, and it is a day biter. So these are the things which make it difficult to control, because mosquitoes which bite in the night, we can use mosquito nets and other preventive measures. But if it is a day biter, it will bite the school children, it will bite the people in occupations and offices. So throughout the day, you are exposed to the bite of the Aedes mosquito, being a day biter. So it is a difficult to prevent the bites. It peaks during rainfalls and small pockets of water. And the Aedes mosquito is a very hardy mosquito. It can survive adverse environmental conditions. Potted plants and all. The eggs are very sturdy and can survive environmental conditions. The virus in the mosquitoes can be transmitted to the next generation trans-ovarian. So if a mosquito is infected with the virus, it passes on to the next generation of mosquitoes also. It's progenies. So that's why it is a major reservoir of the virus. So it's a challenge, extra human reservoir, day biter. So there are multiple challenges to control dengue. So these are, as you have already said, that it has got black and white stripes on its legs and wings. So that's why it is called tiger mosquito. So you can identify it in the daytime. Small water collections, just some rainfall, or some people are having balconies, they are having the balcony gardens or potted plants. So little water is enough for the hatching and breeding of these Aedes mosquitoes around the houses. So this is about the transmission and the vector. Now we are coming to the core issue. To understand antibody dependent enhancement, you have to understand the dengue virus, the types of serotypes. So basically there are 4 serotypes: DNV1, 2, 3, and 4. 4 different serotypes. And I think a decade back, a fifth also has been identified in Malaysia. But basically, we are dealing with 4 serotypes. And unfortunate thing is that there is the person gets infected with one serotype, that person will develop lifelong immunity against that other serotypes, or that serotype, not on other serotypes. Other serotypes, the protection is temporary. It will be protected for some time, but there is waning of immunity. There are waning of neutralizing antibodies. So those becomes weak against the other serotypes, and that is the reason for antibody dependent enhancement. We'll see how it works. There's only a small window of protection against the other serotypes when the titer is very high. So though the antigens are more or less similar of the 4 serotypes, there are differences, diversity in the sequences, which makes it very specific. Antibody lifelong immunity is very specific, and if the person gets infected with another serotype, there are more chances, 5 to 10% chances of ADE, antibody dependent enhancement. So limited protection against heterotopic infections by other 3 serotypes. Cross protection is short-lived. After this short window of protection, subsequent infection with a different serotype may increase the risk of developing severe dengue. Now, what is this antibody development enhancer? It is mediated by immunoglobulins. As you know, the antibodies are called immunoglobulins, IgG, IgM. Initial one is IgM, subsequently IgG. And this IgG is responsible for severity in secondary dengue infection, for AD. What happens is that after a time, initially, if a person gets, say, infected with dengue 1 serotype, first serotype, and after, say, a few years, he or she gets infected with another serotype, that person is vulnerable. The longer the gap between the 2 infections, the more the vulnerability, because the shorter the gap, if the gap is very short, there is cross protection. There is a window of protection. But as the level of antibody decreases, the protection against the other serotypes, the neutralizing capacity against the different serotype wanes. And when this happens, this antibody, which is supposed to act like a sentry, instead becomes the collaborator. Like you have got a chowkidar for your house, and that chowkidar becomes weak, and he will form a partnership with the robber, with the person who wants to loot your house, and will facilitate the entry of that robber and rob your things. So this is just to make it very simple. This is what happens when a weak chowkidar is there. He enters into a partnership with the robber. So this is what happens when the antibody become weak and non-neutralizing against the other serotypes. If there is an infection with that other serotypes, it combines with that and form the complexes, and on the receptor of the immune cells, T cells and other immune cells, Fc gamma receptors, Fc protein gets attached and enters those cells, and there is replication of the virus. So that is enhancement, antibody dependent enhancement. This antibody, which is supposed to protect you, it forms liaison with the new strain, different strain, and allows it enter into the through this Fc gamma receptors. That door is open and it enters the immune cells, and there is amplification of the viremia, which can give rise to very severe dengue in the form of dengue, hemorrhagic fever, dengue, shock syndrome, leaking of permeability of capillaries and blood and into the other compartments, fluid overload. So these are the sequence of events. So unfortunately that there is no cross immunity against, in fact, it becomes a handicap. This promotes viral application leading to increased viremia, higher vascular hyperpermeability, severe dengue. I just explained the concept. Molecular mechanisms are still not fully understood, and it's not my expertise also. The virologists are working on it, and I'll be giving some references. Those who are interested can read this up. So what are the viral and host factors for ADE? So dengue virus has a positive sense RNA genome that encodes for 7 non-structural proteins and 3 structural glycoproteins. The cell, the envelope E, and the pre-membrane. So these are the structural proteins, and others are non-structural. And these are the responsible for viral attachment, entry, and maturation. Although all serotypes are closely related, as I said, a significant degree of sequence diversity exists. Maybe the amino acid sequence or whatever building block sequence, there is a diversity. As a result, a subset of from one serotype may cross-react with those from other serotypes and exhibit poor neutralization effect. When the neutralization effect is poor, those antibody which is supposed to protect you, it enters into partnership with the attacker and facilitates the entry into the immune cells and multiplication. Decreased neutralizing antibodies due to waning immunity also predisposed to ADE. Decrease in matter. Acha, this is another, some studies have established very elegantly that mothers who have had a dengue infection, they will have the metal antibodies, but they gradually the antibodies will fall. And if they give birth to a child, that child has got metal antibodies, but again waning. And if that child gets a first infection with, after birth, gets a first infection with any strain which is not same as the strain in by which his or her mother had suffered, there can be a antibody dependent enhancement. So because mother has suffered in the past, there is a lot of gap. She has given birth, the child grows up, and some maternal antibodies are there, newborn child. So it higher levels of A phosphorylated anti-IgG, a significant factor for thrombocytopenia. So again, these antibodies, these are changes Fiscolin is a protein which is missing in this IgG due to waning immunity. That also gives rise to thrombocytopenia, falling platelet count and other things which complicates dengue. So there are two mechanisms. One is the extrinsic antibody dependent enhancement. That is the externally they are forming the lesion. The antibodies in the first mechanism is fragmented crystalline gamma receptors, that FCYR, that is on the surface of the immune cells. This is mediated through that, which uses the FC protein on the immunoglobulin. The immunoglobulin, which is non-neutralizing, which has become weak, that forms partnership with the immune cells on the receptors, FCY receptors. This FC of the immunoglobulin attaches to the FC gamma receptor, and their FC on immune cells and facilitates the viral entry into the immune cells. That is the external partnership. And once it enters by enhancing the internalization, the viral load augments. Once it enters the immune cells, and starts a vicious cycle in which more cells are targets of virus internalization, and intracellularly dengue virus starts suppressing the innate immune signaling. So this is the extrinsic and this is the intrinsic. Once it enters, changes in the E protein and creating virus-friendly environment. So they have entered the sanctum sanctorum of the immune system. There are the T cells and other macrophages and other things which are supposed to fight the virus. They are being dominated by the virus which has entered their inside them, and they are multiplying. So this is the flow diagram, antibody-dependent enhancement. The extrinsic ADE is virus antibody complexes form. The antibodies, the weaker antibodies, they form with the virus, and these complexes enter the virus antibody. They are mediated, and intrinsic, once that changes in E protein and creating virus-friendly environment inside the immune cells. So these are the diagram of it. If you see from top, this is DNV is the dengue virus, and the IgG antibodies are the Y-shaped structures shown. So these are the macrophage. Below that is the macrophage, and if you see the FC gamma receptors are the shown as the two hooks on the surface of the macrophages. So this complex, the virus antibody complex, they have combined together and they are attaching on these receptors on the macrophage. On the three sides, you will see the pair of receptors all around, three pairs you are seeing. And once they attach to that, and the last bottom, they have entered the macrophage or T cells or whatever immune cell, and they are multiplying. The virus is multiplying inside. So this is the diagrammatically, it is depicting the antibody dependent enhancement. So what are the implications of ADE for clinical practice? Evidence suggests that enhancing and cross-reactive neutralizing antibodies regulate dengue disease severity. In this sense, epidemiological and serological observations made during Cuban dengue is a very good population level study. They have studied two epidemics of dengue in Cuba over a gap of 20 years. As I said, the more the gap, the chances of AD increases because the neutralizing power of the antibodies against the other strains become weaker. And once it becomes weaker, it forms partnership with the virus and takes it inside those macrophages and अपने ही घर में चोरी कराता है वो. तो if it is a same strain, second pandemic outbreak is also of the same strain, then there is a protection because it is loyal to its own strain. Dengue 1, second again, but if it is other serotype, the more the gap, the weaker the neutralizing power of the antibodies, and weaker the neutralizing power of the antibodies, the more affinity to form partnership with the virus and invade the macrophages and enhance the virus replication. So they have seen that even after a gap of 20 years, when the population was infected with a different strain, there were very severe cases of dengue. A marked increase in severity associated with the longer the two intervals, 20 years versus 4 years. If the interval is short, the less cases, interval is long, more cases. Because immediately there is a cross protection against other strains also, a small window. In addition, some sequences of dengue 1 followed dengue 2 followed by dengue have been associated with greater disease severity. So they have different permutations and combinations. Some are more closer to each other, some are more diverse. So they are different on the sequence of the strain which is infecting the population also. So now what are the implications for public health? The clinical implications of management becomes difficult because you expect more cases of thrombocytopenia, platelet fall, bleeding tendency, hemorrhagic fever, dengue hemorrhagic fever, shock syndrome. So that clinical management becomes difficult if there is large number of ADE, if the two sequential outbreaks are from different strains. And the longer the gap, more the possibility of ADE. Implications for public health. Early studies in Thailand recognize that dengue hemorrhagic fever and dengue software peaked in the population first time. In fact, infants born to dengue immune mothers and children who had experienced mild or asymptomatic dengue infection and become secondary infected by different strains. So as I had mentioned, the mother had got, the child is vulnerable. If they are strain, or a child, mother has not suffered, but the child suffers a mild asymptomatic from one strain, subsequent the child is vulnerable if the subsequent strain infecting the child is a different serotype than what the child got previously. These studies suggest that dengue hemorrhagic fever and dengue short syndrome is 15 to 80 times more frequent in secondary infection than in primary ones, and that up to 99% of dengue hemorrhagic fever cases reveal heterotypic antibody. Heterotypic means other antibodies to the dengue serotype causing the DHF. Other antibodies which has become weak against other strain. So these first observations were confirmed by a different setting, the dengue virus 2 epidemic of 1981, preceded by a mild epidemic of dengue virus 1 in 97 in Cuba, supported secondary infections as a main risk factor for the severe forms of dengue infections. So at the population level also these things are manifested. And if that's why it's important to know if there's an outbreak in a population, what was the strain, so that once after a few years again there's an outbreak, if you know it is the same strain, you can be comfortable. In fact, there won't be an outbreak because there will be a sort of a immunity, because the immunity is loyal to that strain. Antibodies, if it is even after years. But if it is a other strain and the gap is longer, the vulnerability increases. So you can expect more cases of dengue shock syndrome and dengue, and you require more hospital beds. So it's important for public health policy planners also to keep a track on the strains which are occurring in a population. So you can anticipate more cases which will require intensive care for management of shock syndrome and hemorrhagic fever. So this is very important. This is the public health implication. In this epidemic, so more than 3 lakh cases, 10,000 severe cases. So 10,000 cases in a population. Thailand is a small country, Cuba is a small country, and very severe cases and 158 fatalities, 101 children. The sequence by sequential outbreaks by different strains. So these are the implications of public health. So anyway, as I said, preventive measures are difficult because of the day biting and the very sturdy mosquito, very sturdy eggs, and little water is enough to make it active again, the larva. And challenge in Aedes mosquitoes are day biters and in schools, workplaces. So now the other hope is the good vaccine, because this is would be very good if you have a vaccine against such a disease where the other measures are very, very difficult to implement and difficult because of the binomics of the vector and the biting habits of the vector. So again there is a challenge, because you have to make a vaccine which has got antibodies against all the four strains with equal. The risk of triggering vaccine-enhanced disease poses a threat during development of an effective and safe vaccine, because you don't know the next outbreak in a community, which will be the strain. So you have to prepare vaccines equitably for all the serotypes. The antibodies should be against all the serotypes, and which is a challenge, because you try to make it, but if there is some sort of inequality, there is a chance of vaccine-induced enhancement. Vaccine antibody dependent enhancement. Antibodies can be elicited by vaccines also. So that again, ADE can be associated with vaccine development. Considering the challenge posed by disease enhancing cross-reactive antibodies, the objectives of vaccine development was to develop a vaccine protective and against all the serotypes in equal measure. So this was the first vaccine developed by, I think, Sanofi. Dengue vaccine is a tetravalent attenuated chimeric yellow fever vaccine introduced in 2015. Actually, what they use the substrate of the existing yellow fever vaccine. On that, they build the dengue vaccine. It incorporates pre-membrane and envelope E gene from dengue serotype into a backbone existing of non-structural genes of yellow fever virus. So this was the vaccine developed, and it had its problems. The problem was dengue vaccine by Sanofi. Phase 1 and phase 2 demonstrated a 3-dose regimen well tolerated in adults. Despite the representation of all serotypes in the tetravalent vaccine, predominantly elicited serotype specific antibody against dengue 4. So, despite attempting to make it equal, in practice, what happened? The more antibodies dominated. The antibodies which dominated were against dengue virus 4. So once there is the others become weaker, and they will try to sabotage by causing AD. As I said, the weaker antibodies will form complexes with the other surface receptors on the macrophages and try to enter the antibody-dependent enhancement. The risk of severe dengue was found to be higher in vaccinated children who were seronegative at baseline. So this inequality in the vaccine antibody response made the children under trial conditions vulnerable to ADE. This vaccine enhanced disease was particularly evident in younger age group too, and due to their lower probability of being exposed to dengue virus. So possible cause of the increased amount of severe dengue may be usage of a yellow fever backbone only incorporated two structural genes. So I don't know, these are very technical terms, but there was a difficulty. We could not develop equally responsive. Due to this non-structural genes of dengue virus, lack of dengue virus non-structural, they took the non-structural genes of a yellow fever virus. In the vaccine of Sanofi Pasteur, the vaccination with dengue vaccine did not result in the production of antibodies against dengue NS1, non-structural dengue 1, but instead to yellow fever NS1. There may be some logistic or technical difficulties. That's why they use the yellow fever. But antibodies against the NS1, non-structural protein of dengue, was not. So these yellow fever NS1 antibodies might bind dengue but not neutralize dengue NS1. So non-neutralizing antibodies. So they generated number of, therefore these yellow fever NS1 antigens hypothetically could play a role in ADE, antibody dependent enhancement, or solely due to lack of a neutralizing antigen. This could result in a more severe disease presentation. So that's why this dengue vaccine is contraindicated in people who had never suffered from a dengue infection. So it cannot be used for travelers. Usually they make the vaccines for people in developed countries. When they travel to tropical areas, they would like to get protected. But this does not serve their purpose. And how much it serves the purpose of people endemic, that also is very difficult to know, because then you can't have a blanket mass vaccination program, because among many people who had never faced the virus, if they get the vaccine and after a couple of years they get the natural infection, there may be a antibody dependent enhancement, because in the vaccines the equitable antibody production against all the four strains are not being achieved. So one strain or the other dominates. So, antibodies against one strain or the other dominates, and those weaker antibodies in subsequent infection can cause the vaccine-induced enhancement. So now there is another vaccine which is very recent. I think in India also they may be planning Dengue. I think this is a Japanese. By the end of 2022, a second live attenuated vaccine targeting all the four strains, licensing under the name of Dengue. I think this is Japanese and has since been registered in various regions, including the European Union. Actually, European and Westerners, they are interested because they travel to tropical areas. So they want a vaccine to be protected while they are traveling. And the dengue vaccine is not serving the purpose. The European Medical Association authorized the tag for in both adults and children aged 4 and above, regardless of serostatus. You see, earlier dengue vaccine, you have to do a serology first. Only if there is no antibodies against any strain, the vaccine was given, but thereby expanding its application in travel medicine. Although vaccine-enhanced disease has not been demonstrated after receiving this dengue, several European countries maintain a cautious policy. So though they are very cautious because handling 4 different serotypes at a time is a bit tricky, and which one will dominate in actual actual practice we don't know. And once there is a imbalance between the antibodies, there are chances of antibody dependent enhancement. So there is still cautious. So that's why as on today, large scale deployment of vaccine is not being done. They are still under trials to refine it further. Hopefully in future, if it is refined, we may have a good vaccine. So this is the conclusion. The 4 strains of dengue virus poses a public health hazard when infections occur by different strains at longer intervals. The longer the interval, the more the enhancement. The resultant antibody dependent enhancement poses a clinical challenge in the form of severe dengue shock syndrome, and dengue hemorrhagic fever. And this ADE also poses a challenge in vaccine development in dengue. So I have just given 4 references because these 4 references has got a lot of references there at the end. So you can get a good overview of the subject. If you go through this, particularly reference number 2, 3, and 4. In fact, reference number 4 is dealing with vaccination also, the role of antibody-dependent enhancement in dengue vaccination. And others are also dealing with the enhancement. So I think that's all. I think I can stop sharing the screen. So if there are any questions, I can take.
Yes, sir. Am I audible?
Yeah.
Okay. So thank you so much, sir, for the comprehensive and insightful talk. The content were very informative. So now, with all your permission, can I share all the questions we have received from the delegates?
Yeah, please.
Okay, sir.
This mechanism, as I tried to explain in very simple terms, is that when there is a infection, as there are 4 different serotypes, the infection occurs with one serotype, and there is a elicitation of good antibody response. Initially, when the antibody titer is high, that gives some cross protection against other serotypes. There are 4 serotypes. So if a person gets infected with serotype 1, for few months or one or 2 years, that person may have enough antibody, strong antibody levels to work against other serotypes. But over time, this protection against the other serotypes diminishes, and it only gives lifelong immunity to that only that strain to which the person has been infected. And when the person is infected by another strain, say strain 2 or strain 3, this the antibodies from the initial infection are not neutralizing that virus. So once they fail to neutralize, they say if you can't lick them, join them. So they join with those viruses, those certain FC, the protein on the antibodies, the IgG on the antibodies, they get attached to the receptors of the virus, and through the help, together with the help of the virus receptor, they enter the immune cells, macrophages and other immune cells, and there is replication of the virus. So this is the mechanism. This is very brief. I have tried to explain because the molecular level still not well understood. But the weak antibodies against the other strains, they join hands with the virus, and then they enter the virus, and then they multiply the virus viremia, severe viremia, and it leads to very severe clinical syndrome. Yeah, exactly. This is what happens because there are similarities of the four serotypes, but there is a sequence. There is a diversity in the sequence of the structure, protein sequence or whatever amino acid sequence. So the once the subsequent infection is of another serotype, the antibodies get confused. They cannot, if the particularly if the between the two infections there is a bigger time gap. For short duration, it acts against all serotypes, but that is only very for a short duration. But after a long duration, it loses the immune memory of other serotypes. Once it loses the immune memory, it wanders and enters the virus, attaches with the receptors and enters the virus, just like person who has lost the memory. Alzheimer's patient may enter some other house. So instead of attacking, it enters the air, and the virus replication it promotes. So this is the problem with this four serotypes. So it does it antibody dependent enhancement increase the viral load many times, 20 to 80 times more it increased. And immune response, it causes immune paralysis. I mean, it destroys the ability of the body's immune system by infiltrating the immune cells. And therefore, there is very severe dengue. There may be capillary thrombocytopenia also. There may be hemorrhage. There may be fluid loss into the other compartments. So this is by it increases the viral load, and on the whole sequence of events start.
Okay, sir. Am I visible?
Yeah.
Okay, sir. Thank you so much for answering all the queries of the delegates. And I would also like to extend my gratitude to all the participating doctors for your consistent engagement. And lastly, before ending the live, I would request you all to follow us on our social media handles to stay updated for the latest medical infos.
Thank you, Rimpa. I am logging out.
Okay, sir. Thank you